One thing I will say about this didactic is that, you know, whenever we talk about CBT for psychosis, we always, want to emphasize the importance of involving family members. In my experience, I think that is particularly the case when we are treating folks that have a predominant negative symptom presentation. It's just not quite as well known. People are not as well educated about negative symptoms and how they present, as they tend to be about hallucinations and delusions or even thought disorder. So I think it's really important that we are educating the family members, even when we're working with people in a group modality. And sometimes this is done through groups for family members, where you provide some psychoeducation, some family psychoeducation. And sometimes it's done one-on-one. I think, do what works best for you, but that should not be a neglected component of treatment for folks with negative symptoms. So as always for these didactics, the way that I structure my didactics is I start with just some basics or fundamental concepts, and then we'll launch into typically a rationale for why we're doing a didactic on this topic, and then some techniques. And I think the basics and the rationale are kind of there's a lot of overlap here. So negative symptoms are an important public health concern. In terms of long-term outcome, what we see is that the extent to which somebody has negative symptoms tends to be a prognostic indicator of their long-term social and occupational functioning, as well as quality of life. We know that negative symptoms tend to be more stable over time than positive or disorganized symptoms. Where we see negative symptoms persisting for longer than a 12-month period, you'll sometimes hear that referred to as a deficit syndrome. And that happens in about 15 to 20% of individuals with schizophrenia. We do know from the literature that negative symptoms do appear to be responsive to CBT for psychosis. So we do have statistically significant effects of CBT for psychosis compared to some kind of comparator treatment, either an inactive comparator treatment like treatment as usual, or an active comparator treatment, but the effect sizes tend to be pretty small. So it is the case for both our medications and our psychotherapeutic interventions for negative symptoms that we see smaller effect sizes for folks that have predominant negative symptoms. Now that is starting to change. And I think the reason why we're starting to see some studies emerging with slightly larger effect sizes for folks with negative symptoms is because we're starting to see more tailored interventions. So for I think many, many decades, we have talked about schizophrenia as a unitary construct. And it is increasingly recognized in the psychiatric community that it is really more appropriate to talk about schizophrenias, that there are many different kinds of presentations, and that the extent to which we can tailor our interventions to these presentations will probably be more successful in our treatments. And so there is recovery-oriented cognitive therapy that is a form of CBT for psychosis coming out of Aaron Beck's lab at the University of Pennsylvania and the Beck Psychopathology Research Institute that is really tailored to folks with negative symptoms. And then cognitive behavioral social skills training, or CBSST, which is really a lot of that work is being done right now by Eric Granholm at UC San Diego. These are the psychotherapeutic forms of psychotherapies that tend to have the largest effect sizes for people with negative symptoms. In general, in CBT for psychosis for folks with negative symptoms, what we're really trying to target is helping people to identify negative symptoms and identify the things that make them worse, and to reduce triggers, and to help them develop strategies to help alleviate negative symptoms and their effects. There is a heavy emphasis in all of our CBTP interventions, but I almost feel like particularly so with negative symptoms. And as I mentioned, for family involvement, in order to facilitate recovery. And I'll share with you at the end of the didactic a book that is geared towards family members that can help facilitate some really crucial psychoeducation so that your family members that you work with can complement the psychoed that you would provide or your team would provide with some bibliotherapy. And I always share sort of an anecdote from my clinical life, which was, having a very well-intentioned caretaker of somebody with really severe negative symptoms complain about how her nephew was lazy, when in fact that was negative symptoms. So it's critical that we facilitate some reattribution and education for our family members. By way of review, we think about negative symptoms as really the absence of things that we usually see present, absence of thoughts, feelings, and behaviors that we see present in folks that do not have negative symptoms. And there's a woman, Nancy Andreessen at University of Iowa, who kind of clusters these into the really 5 A's that she categorized them as: avolition, meaning little motivation, difficulty starting and completing tasks. And then she also talked about anhedonia, which is really the absence of pleasure, alogia, which is either a slowness to respond or either poverty of speech or poverty of speech content, meaning they are saying something, but the substance isn't really there. And then affect, either blunting or flattening, and then attentional deficits that we will often see as part of the general syndrome, schizophrenia syndrome. And then I've added to that this asociality, which is the social withdrawal that we typically see in individuals with negative symptoms. And then what I did was, and I didn't actually do this, this came from a 1994 paper that I referenced at the bottom, but you can see the different kinds of negative symptoms in the right-hand column, and then neuroleptic side effects on the left-hand column. So you can see the degree of overlap that we have. And so it's very often difficult to parse out what is a negative symptom presentation from what is an antipsychotic side effect. And then when we add on to that the fact that we know that a great deal, in fact, most of our folks with schizophrenia will present particularly in between psychotic episodes with demoralization or depression, you can see it's a very complicated clinical picture to really get a good handle on negative symptoms as a differential. And then just one more wrinkle that we all need to be attuned to in terms of really identifying, whether negative symptoms are at play, are the number of losses that are associated with a diagnosis of a schizophrenia spectrum disorder. We have this just as a few of them. Many of our folks, when they're diagnosed, will be in this period of bereavement that, for some people doesn't really resolve, that they always sort of see themselves as a function of this diagnosis. My life is not going to amount to much. I'm never going to be a healthy, functional person. I won't have healthy relationships. And so all of these losses can also present as negative symptoms. When we think about negative symptoms from a cognitive perspective, not surprisingly, we see thoughts as the underlying problem that presents as a negative symptom. And the 3 kinds of thoughts that we typically see coincide with a negative symptom presentation are defeatist beliefs, right? This is not going to work out is an example of a defeatist belief. Asocial beliefs, why would I interact with other people? It's not going to be enjoyable. And then negative expectancies, right? Expecting that something in the future is not going to turn out well, not going to be worthwhile, not going to go well. And then the other piece to the cognitive conceptualization of negative symptoms that I think is important to know in its own right, and perhaps also to be factored into psychoeducation with families, is to talk about this idea that a positive psychotic episode is a neurological assault. And that one theory about negative symptoms is that if you think about what happens in negative symptoms, it's like an effort to reduce overstimulation, or to really just reduce stimulation in general. And it is a period of time during which the brain is attempting to heal itself. And so it's trying to reduce as much output as possible. And in order to reduce output, you have to reduce input. So if you think about like the person that I have treated with just the most pronounced negative symptoms was literally in his room, which was in the basement of his house, staring at a blank wall with the lights off for most of the day, for about 16 hours a day, and then he was sleeping the other hours. So really very little stimulation whatsoever, but that the idea is that this can serve a restorative purpose. What happens though, of course, is that people get stuck in that period. And so our task then is to help move them out of that restorative period and into more of a healing and rehabilitation period. But in order to do that, we have to be able to tackle defeatist beliefs, asocial beliefs, and negative expectancies. So implications for treatment. We know that our folks with negative symptoms have a high risk of early termination of services. And so because of that, we really want to front load, not just front load engagement, which we do for everybody, but we want to make a special effort at engagement for folks with negative symptoms. And so what might this look like in a group format? It might look like, having more activities in the group that are going to be enjoyable. And I should say just on that note, because I did have anhedonia up there on the list as an inability to experience pleasure. But the theory in terms of how this presents for folks with negative symptoms is that they're perfectly capable of experiencing pleasure and enjoyment. They just don't expect that something will be enjoyable. And so it's very important to give people opportunities to engage in pleasurable activities, and then to ask them before the activity, how enjoyable do you think this is going to be? And then to check in with them after the activity to see how enjoyable it was. And then to use that as a point of reflection to hopefully build on that so they'll be more likely to engage in pleasurable activities in the future. In your individual groups, in your group sessions, you'll want to use engagement strategies at the start of each session, thinking about things that are going to be engaging to these group members, and potentially to be working with them to the extent possible outside of group. And that's where it can be really important to leverage other members of the clinical team, whether that's inpatient, outpatient, specialty care, to make sure that our folks with negative symptoms are having a lot of contact with mental health providers, and that those points of contact are rewarding for them. And then anytime we're thinking about homework, one of the benefits of our group workbook that we use is that it has suggestions for home practice embedded in each of the sessions. But we want to be thinking about, for our folks with negative symptoms, is this worksheet heavy and therefore less likely to be helpful, or not helpful, but completed by somebody with negative symptoms? How can I tweak this so that they're more likely to apply this to their life? And trying to aim for a 90% likelihood that the person is saying, when you ask them, how likely are you to be able to, to do this week, that they're hopefully saying 90%. Anything under 75% for sure is just not going to happen. And so thinking about, how do I tweak this to make it more likely that the person will actually have a success experience with this? And I think in terms of success experience, I don't mean that they succeed in whatever the endeavor was. I mean that they succeed in actually adding it to their week, that they actually try it out that week. And then thinking with the person, okay, what might get in the way? Given that we know that amotivation is something that they're probably contending with, how do we strategize in advance for them just not feeling like doing it? How do we have maybe other group members help hold each other accountable? How can they include family and caregivers? And then in terms of behavioral experiments, it really is about just testing out some of the defeatist beliefs or negative expectancy beliefs, right? Like, I could never do that. Well, what if you actually tested that out? Like you did a little experiment this week and you actually tested out that belief that you couldn't do it. How would we go about setting that up? And that's just a way to tweak the home practice and make sure that you are targeting beliefs at the same time. I've already talked about psychoeducation and how critical it is both for the client as well as their natural supports. I think discussing medications is critically important, particularly because the antipsychotics, not only do they have a lot of unpleasant side effects, but some of the side effects might even be exacerbating negative symptoms. And I think for a long time in psychiatric care, we've tried to, push that under the rug and not call attention to it, but it's a legitimate concern. And I think it's important that we have that dialogue with them, that is a risk, and that oftentimes, the prescriber is doing his or her best to try to balance the negative and the positive symptoms. There is a tool called the payoff matrix that, if you're not familiar, it's also called the decisional balance. If you're not familiar with it, we could even do a didactic just on the payoff matrix. It's a really cool tool that can help to highlight some of the unacknowledged benefits of negative symptoms to doing less. And we don't really talk about that, right? Because the negative symptoms are impairing and to varying degrees distressing to people. I think if we can talk about the idea that for a lot of folks with negative symptoms, there is a fear that if I try something else, I'm going to fail. And a lot of our folks with negative symptoms really have these high performance expectations, or did before the psychosis started, and their families are often high performing and have a lot of high expectations. And so there can be a belief there that, well, if I try and I fail, that's worse than not even trying at all, or something to that effect. And the payoff matrix can help to unearth some of these kinds of beliefs and to start having different discussions around them. And then I think talking with the family members about the need to balance convalescence with increased activity. And the analogy that I will give to family members is that it's a bit like when you have the flu and your body, sort of forces you to shut down into, like everything is strenuous. And so you're doing a lot less. And that's good because it helps your body start, to fight the infection and to start to repair itself. The same thing happens with negative symptoms. However, like with the flu, if you stay in bed and you don't, kind of eventually start to increase your activity, you'll actually feel worse even when the virus is kicked out of your system. And so similarly with negative symptoms, we're trying to increase the activity, but also balance that with that genuine need for convalescence. Because we're asking people to start building in activity into their day, it's important to get a sense of what they're doing now. I will say that this area is not well emphasized in your group materials. There's definitely much more of an emphasis on depression and hallucinations and delusions versus negative symptoms. So this is that self-monitoring might be something that if you've got a lot of folks with negative symptoms in your groups, you decide to build into that. And then behavioral activation, really targeting two different areas. One is activities that increase pleasure, and the other is increasing activities that increase the sense of mastery that a person feels, how competent and capable they feel. And really starting to develop that into a routine, and then targeting social skills training. I will say there is that cognitive behavioral social skills training is actually designed as a group intervention. And if you're interested, I could recommend the group CBSST workbook. I think it would be a phenomenal addition to agencies that are trying to better serve this population. And then finally, really ensuring that we're targeting those cognitions that underlie negative symptoms and using a variety of the strategies that are included in the group workbook, like the ABCs, to target these cognitions.